Thallium goes into thela, thallium goes into thela, thallium goes into thela, a capillary like potential hotspot. Normal cardiac normal cells infarct cause cause technician venous spinal Stennis below this has been stunted. This has been stunted. Alexa, volume 10.
Just looking at these names because we don't study these often. So what I'm going to do is just summarize this topic for you, which is about all of the nuclear medicine investigations of the heart. All right. So just listen to me patiently now. So when we talk about the nuclear medicine investigations, first I have ischemia imaging. Yeah. So I want to see what is ischemic in the heart. Second, I want to talk about the ventricular function, which was asked here: ejection fraction, ventricular function, any functional study. Let's talk about this first. When we have any functional study, there are three things which I can do for assessing the ventricular function. One is an echocardiography. That is what is most commonly done. So echo is something that we do most commonly for assessing ventricular function. Second study I have is a Muga scan. This is a nuclear medicine scan where I label RBCs with technetium 99. Technetium 99 labeled RBCs I've put, they are going through the ventricle, I can measure the function. And third is an MRI. So echo, most commonly done for function. The investigation of choice, the best for assessing ventricular function, the best for assessing ejection fraction is MRI. Right? This was your answer. Muga का full form जानने की जरूरत नहीं है, multi-gated acquisition. If I'm not telling you something, I'm not telling you for a reason. जितना पता होना चाहिए, I am telling you. So echo, Muga scan, MRI. Now we talk about ischemia imaging. Now when we talk about ischemia imaging, I can either measure the area which are ischemic. That is by the perfusion studies. So we have myocardial perfusion imaging. Myocardial perfusion imaging can be done with three things. Most commonly we use thallium studies. All right, thallium use karte hain. We can also use sestamine. Sestamine you have heard with parathyroid adenoma. All right, so sestamine I can use here also. Okay, so this is there, and then there is something known as tetrophosmin. So these are what are used for assessing perfusion. जहाँ पे भी blood vessel है, these radionucleotides will go. So wherever there is ischemia or infarct, tell me that will be a cold spot or a hot spot. It will be a cold spot because there the technetium is not going, right? Apart from this, I can directly bind to the infarct. I can have a technetium analog which can directly bind to the infarct. This is known as technetium 99 pyrophosphate. So pyrophosphate, the infarct is only going to appear as a hotspot. It binds to the infarct. So this is pyro. Pyro means fire. Fire means hot. So this is in a nutshell all things you need to know about imaging of heart. So when I talk about ventricular function, it is MRI. Cardiac MRI, remember, is a very advanced investigation. What we do is ECG gating. In the last radio class I was talking about it, we do a ECG gating. I can measure the heart beating. I can see the rhythm here, all right? So that's why it talks about every measurement. It can talk about ejection fraction. It can tell us the regurgitant fraction. It can tell us everything, right? So this is what you need to remember. It talks about every measurement. It can talk about ejection fraction. It can tell us the regurgitant fraction. It can tell us everything, right? So this is what you need to remember, that the answer to this is cardiac MRI. You know about thallium now. Thallium myocardial perfusion imaging. Pyrophosphate or infarct. Bach gaya FDG PET. If they ask you investigation of choice for viability, yeah, for myocardial viability, it is going to be FDG PET because wherever you have viable myocardium, you'll have the PET bind to it. Okay, so this is the investigation of choice for viability. So this is what you need to know as far as the cardiac scans are concerned. Okay. So moving on to the next one. Moving on to the next one. You have a young woman coming to the office with a mass at her right wrist. So I've shown you the image here. They've given the history that काफी महीनों से है. Hyperlipidemia RA. What is very important? It is mobile and it is trans-illuminating, meaning it has to be a
Forty-two-year-old woman comes to the office with a full circulation of the mass at the right wrist. The patient notices swelling in the first few months after spending week knitting blanket for her family. Medical condition: hyperlipidemia.
a lipoma will not transilluminate. A soft tissue rheumatoid nodule will not transilluminate. So either it is an epidermoid cyst or it's a ganglion cyst. So what is likely near pen रखे दो pen रखे radio class I was talking about and routinely in all patients. All right, could also is once must have seen a so I RA. What is very important? It is mobile and it is trans illuminating. Mean image here they've given the history that काफी महीनों से है hyperlipidemia RA. What is very important? It is mobile and it is trans illuminating, meaning it has to be a cyst. A lipoma will not trans illuminate. A soft tissue rheumatoid nodule will not trans illuminate. So either it is an epidermoid cyst or it's a ganglion cyst. So what is more likely near the joints? It's going to be a ganglion cyst. I think everybody in their lives once must have seen a ganglion cyst in this location only near a wrist. If you have not seen, you will see in your lifetime once at least. Okay, so this is what is a ganglion cyst. Usually it communicates with the joint. Tell me what you will do next. A, excision. B, reassurance and conservative management. C, incision and drainage. D, biopsy. Yeah, you do nothing. It resolves also. In most cases, it can resolve spontaneously. You do nothing. You just reassure the patient, right? So this is a ganglion cyst. This is a typical ganglion cyst. Why not epidermoid cyst? Remember, epidermoid cyst in the soft tissue is the same as sebaceous cyst. What? Typical ganglion also. It be reassurance and conservative management. This is what is a ganglion cyst. Usually it communicates with the joint. Tell me what you will do next. A, excision. B, reassurance and conservative management. C, incision and drainage. D, biopsy. Yeah, you do nothing. It resolves also. In most cases, it can resolve spontaneously. You do nothing. You just reassure the patient, right? So this is a ganglion cyst. This is a typical ganglion cyst. Why not epidermoid cyst? Remember, epidermoid cyst in the soft tissue is the same as sebaceous cyst. One, it will not transilluminate. Even if the name is a cyst, it will not be completely transilluminant. And secondly, you will see a black opening, which is known as a punctum. Remember, we have seen this in surgery. So this is what you need to remember here. Fine. Ganglion cyst is non-tender. Yeah, it is completely punctum. Remember, we have seen it, even if the name. Why not epidermoid cyst? Remember, epidermoid cyst in the soft tissue is the same as sebaceous cyst. One, it will not transilluminate. Even if the name is a cyst, it will not be completely transilluminant. And secondly, you will see a black opening, which is known as a punctum. Remember, we have seen this in surgery. So this is what you need to remember here. Fine. Ganglion cyst is not opening, which is known as a punctum. Remember, we have seen this in surgery. So this is what you need to remember here. Cyst in the soft tissue is the same as sebaceous cyst. One, it will illuminate. Even if the name is a cyst, it will not be completely transilluminant. And secondly, you will see a black opening, which is known as a punctum. Remember, we have seen this in surgery. So this is what you need to remember here. Fine. Ganglion cyst is not tender. Yeah, it is a
ऑर्थो में जाओ, जैसे ऑर्थो में जाओगे, हाँ हाँ जाओ, चलो चलो ऑर्थो में। Most mass of swelling in the hand and wrist. Hand and wrist.
volar side. This is your Jersey finger. You can use a frog spleen here also. The next condition that we're going to talk about is ganglion. It is the most common cause of a swelling on the hand. It is the most common cause of a swelling at the hand. It is a unilocular swelling. It's basically just an out pouch of your synovial cavity or the tendon sheath. It's a unilocular swelling arising from the what is ganglion. It is the most common cause of a swelling on the hand. It is the most common cause of a swelling at the hand. It is a unilocular swelling. It's basically just an out pouch of your synovial cavity or the tendon sheath. It's a unilocular swelling arising from the synovium. Now this synovium can be of the tendon or the joint. It's just an out pouch. Okay, so say this was your tendon. And now there is an out pouch and it's just gathered there. It collects mucinous fluid. It occurs most commonly on the dorsal side. What is the treatment? Can ignore it if the patient has pain. You can aspirate it, inject it with sclerosants or steroids. That's it. That's ganglion. It is the most common cause of swelling at the hand. Aspirate the contents of the cyst, followed by you can inject steroids or sclerosants. Or if it recurs, you can go ahead and do a surgical excision. This is your normal ganglion cyst. A lot of you may be having this. Sometimes you may have pain in certain weathers, and sometimes you don't have. There is something known as compound palmar ganglion. What is compound palmar ganglion? It is a misnomer. It's neither compound nor ganglion. What is it? It is nothing but chronic inflammation of the flexor sheath of your hand and forearm. So here is the flexor sheath of your forearm and the hand, and you have a flexor retinaculum under which the carpal tunnel is there. Remember the flexor retinaculum? So this flexor sheath undergoes chronic inflammation, start to swell. So there is swelling here, and the swelling is in the shape of an hourglass. Okay, chronic inflammation of the flexor sheath, seen in tuberculosis or rheumatoid arthritis, it is in the shape of hourglass. That is your compound palmar ganglion. Okay, compound palmar ganglion हो गया, ganglion. Here, the next condition we want to talk about is chondromalacia patellae. As the name suggests, chondro means cartilage, malacia means softening, patella means of the patella. This is idiopathic. We don't know why it occurs. We really don't know why it occurs, but it occurs in young females. Young females. What happens for some reason which we do not know of? The articular cartilage of patella becomes soft, and when it becomes soft, it causes pain. And when does it cause pain? When it gets compressed on the femur. And when is it getting compressed on femur? When you sit for a very long time, and when you start to get up, you will have anterior knee pain. You will have anterior knee pain. So after prolonged sitting, when you get up, you will have anterior knee pain. So on getting up from prolonged sitting, female, think of chondromalacia patellae, and you have a diagnostic sign for this also. It is called movie sign. Movie sign. Why is it called movie sign? Because when you go to watch a movie, you sit for long durations, and once the movie is over, you start to get up and walk, you will have anterior knee pain. Chondromalacia patellae. Okay? Then there is something known as Baker cyst, popliteal cyst, or Morin Baker cyst. What is it? It is basically a pulsion diverticulum of the synovium. It's a pressure or pulsion diverticulum of your synovium, either of the bursa or of the capsule of the joint. Okay. Now the swelling bulges out posterior to the popliteal fossa. Okay. Swelling becomes prominent on knee extension and disappears on flexion. Can you see this? The swelling bulges out. Can you see this pulsion diverticulum coming from your joint, and becomes visible on extension and disappears on flexion. Can you see the continuity of this pulsion diverticulum? Right? What are the causes? Osteoarthritis is a very important cause. Other causes are rheumatoid arthritis. Investigation can be ultrasound. You do an ultrasound, you see a fluid connection with the joint. Treatment is you can either neglect it if the patient has no symptoms. If the patient has pain, you can go and surgically excise it. That is your Baker cyst, popliteal cyst. Reason it's called popliteal cyst because it's in the popliteal region. It's nothing but a pulsion diverticulum of the capsule or the bursa. Then there was this remote question that was asked: snapping syndrome. There is a snapping knee syndrome and a snapping hip syndrome. What is a snapping knee syndrome? Iliotibial band, when it inserts on the tibia, has a free area over the lateral condyle of the femur. So as you flex and extend it slips over the lateral femoral condyle. It slips over the lateral femoral condyle and you will feel a snap at the lateral spot of your knee. Sometimes it will be painful. It is called as iliotibial band syndrome or snapping knee syndrome. Okay. Now, if the same iliotibial band snaps at the greater trochanter of the hip, we call it snapping hip. Same iliotibial band snapping at the lateral condyle of the hip,
All right, that's all that you have to remember. 40-year-old man comes to the ED due to worsening right lower abdominal pain that radiates to the right groin. ऐसे देख के लग रहा था कि stone है. But then it gets interesting. 2 weeks ago, he was treated for furunculosis of the right thigh, type 1 diabetes, and that's why he was predisposed to this. Takes Okay, tenderness in the right lower quadrant, all right, could also be appendicitis. No masses are palpated, bowel sounds are present, but something interesting. Extension of the right hip increases the pain and flexion decreases the pain. So this is the typical psoas sign. So given his history of no history, given his history of type 1 diabetes when he's predisposed to infection and the pain that he has right lower abdominal pain, what we have to think in the form of psoas abscess. So he's predisposed to infection and the pain that he has right lower abdominal pain, this is what we have to think in the form of psoas abscess. So he had this furunculosis which may have extended into the psoas, leading to psoas abscess. All right, same also seen in appendicitis. Yeah, so this will also be seen in appendicitis, which is the psoas sign, but his history of an infection, right? Already he has had an infection that can extend into the psoas, right? So this is why. And you would have some sort of rebound tenderness, some sort of guarding if there was acute appendicitis, right? And a 40-year-old with acute appendicitis, again, is something which is unlikely. Bowel sounds would be affected, tenderness, some sort of guarding if there was acute appendicitis, right? And a 40-year-old with acute appendicitis, again, is something which is unlikely. Bowel sounds would be affected if there was acute appendicitis. Yeah, so that is one. Okay, so this is psoas abscess, right? Okay. Pain increases on flexion in appendicitis, yes, but again, appendix position is always an issue, right? So appendicitis can also show you the psoas sign, but here this is definitely. I mean, you can in no way rule out psoas abscess. Do you know what I mean? I can still rule out acute appendicitis on the basis of age, on the basis of bowel sounds. There is no point against psoas abscess here because he has had an infection and he is having the typical psoas sign. So that's what you have to first think of. Okay, right. Next, 4-month-old girl is diagnosed with a febrile UTI. So UTI hai, MCU has been shown. So whenever you have an MCU showing contrast going in the ureter, this is vesico-ureteric reflux. The mechanism of UR is because there is a short intravesical ureter length, which results in this sphincter effect. So the sphincter effect is gone and you will have reflux. So ismet, I hopefully no doubt is there. So this is BUR, right? Next, direct repeat question of surgery. Gone and you will So Ismet, I hopefully no doubt is there. So this is VUR, right? Next, direct repeat question of surgery. Which is which of the following statement is true regarding retrosternal? So is it operated by midline sternotomy? No, it is operated by the neck incision. Majority of the vessels derived from mediastinum, no, they get their vessels from the neck vessels, thyroid arteries only. Operated only if the patient is symptomatic, or CT MRI has to be done routinely in all patients. Both are questions which are, both are statements which are relatively true only. Nothing is wrong here, but which is a better answer? So this is controversial question, but this is how the question came. So in my opinion, what we do when anytime we are expecting retrosternal goiter, we have to do their imaging, right? We have to do their CT or MRI to know the extent. An X-ray will never show you the extent. So CT MRI has to be done in any case of retrosternal goiter to see the extension in the thorax. In the thorax, to see where it is going, how will we know? We'll not know, right? So it is done routinely in all patients. It is. Nothing is wrong here. So this, in my opinion, will be a better answer. All right, this is something which is definitely true. We may operate even if the patient is asymptomatic, because these patients can develop dyspnea. We don't want to wait. Na, कि तुम dyspnea develop करो तभी हम निकालेंगे. Already it has extended so much. They can have tracheomalacia also. So we don't want it to be there, right? So that's why I mean, in my opinion, D is better. But as I said, it is controversial, right? It is controversial, but I explained why D is something that you would do because we want to know the extent. All right, I hope this is clear. Next, patient has difficulty in direct question. Patient had difficulty in walking upstairs. When he was made to bear weight on right lower limb, left-sided pelvis drooped down. So Dolly droop of opposite side. So left droop, but the problem is in the right side. And obviously we know it is always the superior gluteal nerve supplying the gluteus medius and minimus, and the bone here is greater trochanter. So either of these on the right side would be the answer. You can't get this question wrong. Okay. Next one. Infant is brought to the OPD when mother notices brown stool. The child looks normal. So brown stool. Red currant jelly stool, radionuclide scan, and whenever you see this radionuclide scan, this is technetium 99 per technate scan, and the diagnosis is Meckel's diverticulum. Again, it will not show uptake in any of these cases. Why? Because technetium per technate binds to the stomach mucosa. You can see here how it's binding to stomach, bladder because it is just excreting. Right, bladder is nothing important, but stomach and Meckel's it binds because mucosa. You can see here how it's binding to stomach, bladder because it is just excreting, right? Bladder is nothing important, but stomach and Meckel's it binds because it is binding to the stomach mucosa. It's the property. Bladder because it is just excreting, right? Bladder is nothing important, but stomach and Meckel's it binds because it is binding to the stomach mucosa. It's the property of technate to bind to stomach. Nobody else has a stomach mucosa. All right. So this is what you need to remember here. Question 7. So इसमें क्या confusion है? Presence of posterior urethral wall is not here. Obstruction due to renal stone, there is no renal stone here. Damage to the rectovaginal septum, again something which is not there only, right? So rectovaginal septum में अगर problem होगा, why would it go into the ureters, right? So there's nothing here to be explained. I hope it is clear. Yeah. So Meckel's diverticulum. Next, why not PUV? For that, Shubhangi, our radio, our surgery has to be thoda. You have to see it once. Okay. Why it is not PUV? Because PUV is where you will be shown the urethra, right? The urethra will be obstructed. This is something we have discussed so many times. Posterior urethra will be dilated. Anterior. Here, what are you seeing? We are seeing that it is going back into the ureter. Okay. So this is what you need to know. And males only have POV. One thing you can rule out without any knowledge of radiology also is posterior urethra तो males में ही होता है, 4 month girl को तो हो ही नहीं सकता, right? So this is what is very important. But you should know the difference between PUV and VWAR. I will be strict with you in these tests because I expect you to have studied before the test, right? Otherwise, don't give the test. कि देखते हैं मजे मजे में. Please study and give these tests. Otherwise, there is no point. Like if you don't know PUV, VWAR, we need to up our game. I'm going to be blunt with you now because we have to collectively do better in the exam. I am as invested in your journey as you are. So you just can't, ask me these questions now at this point when we are just doing a closure of every subject. Yes. All right. 28-year-old man comes to the office for evaluation of left testicular mass. Unless proven otherwise, every testicular mass is going to be a germ cell tumor. Mass has been present for 2 months, has an increased in size, no pain, doesn't matter. What we see is a solid hypoechoic left testicular mass. What is the next best step in the management of these patients? So antibiotics, no. Can I ever do FNAC biopsy for testicular tumor? No. The first thing that we do is a HERO, radical inguinal orchidectomy, high inguinal radical orchidectomy or HERO. Right. So this is what is our next step. Apart from this, if I had given you tumor markers, that would have been a better answer, right? Because HERO. Right. So this is what is our next step. Apart from this, if I had given you tumor markers, that would have been a better answer, right? Because that is non-invasive. So the initial investigation, if they ask you initial investigation, answer would be ultrasound plus tumor marker. So ultrasound they had given, but tumor marker if they have given in the option, then that is a better answer. And then you go for HERO. This is the best for T staging. Okay, so this is the best for T staging. All right, so this is what you need to remember here. Okay, next. 30-year-old woman comes to the office due to pain over the leg. T staging. Given in the option, and that is a better answer. And then you go for hero. This is the best for T staging. Okay, so this is the best for T staging. All right, so this is what you need to remember here. Okay, next. 30-year-old woman comes to the office due to pain over the lateral side of the right wrist for the last one. Very easy question, right? So postpartum hair, what do you see? Fingers closed over the thumb, passive adduction of the wrist reproduces the pain. So this is tenderness in the anatomical stuff box, first extensor tendon affected, right? So what is this? This is D. Querian stenosynovitis. This will be your Finkelstein test. Okay. There's something called each of test, which looks very similar. So what is this? This is D. Querian stenosynovitis. This will be your Finkelstein test. Okay. There's some something called each of test, which looks very similar to Finkelstein test as well. But I mean, just remember for the exam, Finkelstein only. All right. So far, that is what has been asked. Okay. So each of test, Finkelstein test, just look at the difference between the two. However, for routine exams, this is enough. If you know de Quervain, you know Finkelstein, you'll get through NEET. Okay. Next, 48-year-old woman comes to the hospital for lap cholecystectomy for gallstones. So we have given GA, endotracheal intubation is given. Immediately when you put needle and you put CO2, you see that there is bradycardia, AV block. So what is the diagnosis? Here. Is it gas embolization? No. Is it inadequate anesthesia, which is causing bradycardia? No, the patient has already been given the anesthesia. This is one of the most common phenomenon. The moment you will insufflate the CO2 gas, because of the peritoneal stretching, there is transient bradycardia, which is noted. Okay, so this is something you should know, that this is something which is transient bradycardia, which is expected out of after insufflating CO2. Okay, so CO2 absorption has not happened. So all of these things are not happening. This is something that you just need to know. This is a phenomenon which is most likely. All of the other things happening are very, very rare, and this is something you will routinely observe. Okay, so what do you need to know here? That when CO2 is insufflated, peritoneum stretches, and because of the vasovagal shock, because of vagal discharge, you're going to have transient tachycardia. Okay, so this is what you need to remember. Nothing needs to be done. It will settle in the mind. Okay, so this is what you need to know. This is just something that is a concept you should be aware of if you were not aware of till now. A delayed IVP is shown. What is the diagnosis? So we can see that contrast is not going into the ureter. This is pelvic-ureteric junction obstruction. I hope nobody will ask me why not staghorn, why not putty kidney, why not renal cyst. Renal cyst will not show as this opacity here. Staghorn obstruction. I hope nobody. A delayed IVP is shown. What is the diagnosis? So we can see that contrast is not going into the is a concept you should be aware of if you were not aware of till now. A delayed IVP is shown. What is the diagnosis? So we can see that contrast is not going into the ureter. This is pelvic-ureteric junction obstruction. I hope nobody will ask me why not staghorn, why not putty kidney, why not renal cyst. Renal cyst will not show as this opacity here. Staghorn calculus will be just pelvic calyceal system calculus on an X-ray, and putty kidney will be completely calcified kidney on an X-ray. So both are Okay, so this is what you need to remember. 25-year-old, this was slightly interesting, I guess. 25-year-old male patient comes to the ED after a road traffic accident. Patient was conscious but severe pain abdomen. उसने देखा कि यहाँ पे local wound, and what do you see? I see bowel coming out. Come on, this is evisceration. Remember this stable from surgery BTR, penetrating trauma. And then what do you see? I see bowel coming out. Come on, this is evisceration. Remember this stable from surgery BTR, penetrating trauma. उसके नीचे लिखा है ये सब in this order only. Stable, gunshot wound, peritoneal breach, evisceration, impaled object. All of these are indications where you directly have to go for OT because I can see one more rectal bleeding or bleeding from any orifice indicates that there is bowel injury, right? So the moment the bowel comes out, this is something where you directly take to OT. Okay, you can't observe no role of CCTE fast, bowel injury है, all right? So you have to take to emergency laparotomy. ये question गलत नहीं हो सकता. If you are doing this question wrong, we have to think again about how we are studying, okay? So this is emergency laparotomy. Think again about how we are studying means that you have to revise better, okay? Don't start questioning entire life. Next, 54-year-old woman underwent surgery for CA breast last year, okay? Painless swelling. Painless swelling hai, venous thrombosis, cellulitis, I will have to rule out, okay? So this is something which will definitely have pain, erythema, which I don't see. What I'm seeing is just swelling. It can't be lymphangiosarcoma. It will take years to develop and there will be these reddish nodules in Stewart-Reed syndrome. Hai? So this is just lymphedema. Okay, so this is what is lymphedema here. I hope this is clear to all of you. Okay, all right. Next, 75-year-old male after a fall in the bathroom and pelvic exit. Again, repeat. So what is this? Here you can see that the limb is shortened. से ही पता लग रहा है what dislocation? Yes, posterior dislocation. Okay, so posterior dislocation of the hip comes up. So that's why the limb is shortened. You can see this that the femur is up, इसलिए limb shortening हो जाएगी. तो answer is one of these. And what do you have, femur or feather? Yes, everybody is telling me it is feather. Very good. It's shortened. You can see this that the femur is up, इसलिए limb shortening हो जाएगी. तो answer is one of these. And what do you have, femur or feather? Yes, everybody is telling me it is feather. Very good. So the only thing and see this that the femur is up, इसलिए limb shortening हो जाएगी. तो answer is one of these. And what do you have, femur or feather? Yes, everybody is telling me it is feather. Very good. So the only thing which fits is this. A भी नहीं है, A भी नहीं है, A भी नहीं है. Right? So it is feather. That is what you have to remember. This is not leg of femur fracture. Don't do this. देखो बाहर निकल गया है ना. It is dislocated. Fracture कहाँ दिखा? Where did you see fracture? There's no fracture. See, so continuous. See, so continuous. Did you think this is fracture? This line? No, this is just the trochanter. Okay, no fracture. Posterior dislocation of hip. Fine. All right. Again, this is so baby easy question. I'm not sick. My voice is actually down. 3-day offline class was there, no? Last 3 days, so my voice is gone completely. That's why I'm seeming serious. I'm not serious. I'm just okay, but my voice is not coming out. That's why. Patient presents to the ED with chronic ear discharge and headache and ear pain. CT revealed the following findings. So what is this? This is which lobe? ये है हमारा frontal lobe. This one is temporal lobe and this one is cerebellum. This is pons. Okay, so if abscess was here, pontine abscess rare, बहुत rare. Cerebellar abscess can be seen. Temporal you are seeing. Frontal can also be seen. Frontal abscess usually मिलता है history of sinusitis के साथ. Okay, history of sinusitis के साथ. ये सारा पीछे का मिलता है with history of CSOM. So I think this guy also had CSOM, no? So this guy also had CSOM, but temporal abscess is something that you are expecting here. Okay, so it's anatomy question. Okay, everybody. Parietal इससे ऊपर रहेगा. Whenever you see brainstem, no? How do you identify pons? One basilar artery. Okay, single basilar artery. This is parietal. Occipital will be above it. The moment you see cerebellum, how do you identify pons? One basilar artery. Okay, single basilar artery. This is parietal. Occipital will be above it. The moment you see cerebellum, ऐसा brain होता है ना? ऐसा थोड़ा थोड़ा. So this is occipital. The moment you see cerebellum, it can't be occipital. No, only one thing can be there, either cerebellum or occipital. So this is cerebellum. Okay, parietal also will be here. Parietal will be here. So when I'm cutting at this point, or probably this point only, parietal is left far behind up. Okay, yeah, normal brain you have seen. ऐसा sagittal में. So when temporal is there, when frontal is there, when cerebellum is there, how will ऊपर का parietal come? ठीक है? So this temporal abscess. Next question. 76-year-old man is admitted to the. हाँ ऐसा question है ना? Cerebellum and occipital. I will show you. I'll teach you normal anatomy. This is only anatomy I can teach. So this was very painful to read only. पूरा painful to read such a long question. पर काफी बुरा होता है इस आदमी के साथ. Let's see. 76-year-old man. उसको कोरोनरी केयर यूनिट में डाला है फॉर कार्डियक कैथेटराइजेशन। उसमें उसको मिल गया मेन कोरोनरी स्टेनोसिस, एलएडी स्टेनोसिस, एंटीप्लेटलेट आर स्टॉप्ड एंड पेशेंट इज कंटिन्यूड ऑन द heparin drip for coronary artery bypass. All right. 5 hours after the catheterization, he goes into shock. We also see back pain. My buzzword are back pain and shock. He denies chest pain. No shortness of breath means no chest complication probably. No hemothorax or pneumothorax most likely. He's also diaphoretic clammy because obviously he is in shock. Neck veins are flat. This tells me no probably no hemothorax or pneumothorax most likely. He's also diaphoretic clammy because obviously he's in shock. Neck veins are flat. This tells me no cardiac tamponade. That was one thing I had to rule out for sure. And so cardiac tamponade rule out ho gaya, but neck veins are flat. So I know for a fact now that he is losing blood, hypovolemic shock plus back pain is what I'm dealing with in one line. And somebody who undergoes catheterization usually undergoes femoral artery puncture. That is how we enter the coronaries. So cardiologists, intervention cardiologists sometimes artery puncture, or sometimes, or most of the times, we as interventional radiologists do femoral artery puncture. So here they have given you also कि उसका puncture हुआ था femoral artery से. So the right groin arterial puncture site is mildly tender without any swelling on groin. So one concept for you is whenever we are doing a femoral artery puncture for interventional radiology, two very scary complications for us are one groin. So one concept for you is whenever we are doing a femoral artery puncture, femoral artery. So the right groin arterial puncture site is mildly tender without any swelling on groin. So one concept for you is whenever we are doing a femoral artery puncture for interventional radiology, two very scary complications for us are one is pseudoaneurysm of the femoral artery, puncture site pseudoaneurysm. But this is not the case. There is no swelling, no bruit, there is no AV fistula or pseudoaneurysm there. But the one which is very scary for us is retroperitoneal hematoma. You know what will happen if we do a high puncture? Let me just tell you a concept here because otherwise we will never get the time to discuss this. So this is the femur bone, looks like it, no? And this is the femoral artery. So we always puncture against the femoral head. We always puncture here against the femoral head so that we can compress. After the puncture is done, the junior most JR उसका काम होता है वहां पे दबा के रखो. You have to press that puncture site for 15 minutes. Okay, यहाँ पे ऐसे दबा के 15 minutes तक you have to sit. So this is here. This is hand of JR1. Okay, he has to puncture here for at least 15 minutes so that the puncture site will heal. By mistake, if you have done a high puncture, this is what we really have to look at. If you didn't do the puncture here, what will happen is this can bleed. There is no compression site. What will the JR1 compress against? Bichara JR1 15 या 20 minute compress karte, there is no bone against it, so it can bleed. The puncture site will remain open. No matter how much time JR1 compresses, this puncture site will remain open and it can bleed and that can go into retroperitoneum. Understood it, everybody? So this is retroperitoneal hematoma, very deadly. The moment you see कि भाई shock or back pain, गए. So this is artery hematoma. So first year GR, this guy is gone. Okay, so what you have to now do, उसकी गलती भी नहीं थी, गलती पंक्चर वाले की थी, right? गलती तो पंक्चर वाले की थी, but whatever. So he receives 1 liter of saline with some symptomatic improvement. Again, strengthening my confidence that is hypovolemic shock. ECG same hai, again, nothing to do with the chest. So diagnosis, what will you do now? How do I see the retroperitoneum? I got to do a CT scan. Troponin करके कुछ नहीं मिलेगा. NG tube, echo. We already ruled out cardiac tamponade. Cardiac tamponade was one issue that the cardiologist could have made an issue with. So this is something that we already ruled out. All right. So this is what we need to remember here. Okay. This is not trauma, no? So Kavya made a very valid question. Ma'am, if patient is unstable, then why CT? So ये trauma में कहाँ पहुँच गए? इतना बड़ा story है ना? This is not trauma case. This is a routine case. So and he did improve, right? 1 liter saline दिया, symptomatic improve. We need to confirm, no, RP hematoma in this case. Right? This is not a trauma patient. Understood? So this is what we need to remember here. Fine. All right. Good question. Did you like this question? So many concepts you understood. Now don't say repeat. After every long explanation, you just write one small word. Repeat. No, please, no, ma'am. Repeat. No, repeat. Okay. Identify the type of knot seen in the image below. So ये क्या है? Is this going away? Do you know our painful pneumonic granny will slip and she goes away? Have I said that in the recorded video? That granny will slip and will go away from us. So this is how you distinguish granny and square knot. So granny goes away. So these two knots have to go away. One will be below, one will be over. Square knot is where they approximate one another, right? So this is a square knot. Square knot is also known as a reef knot. Surgeon's knot is char and do, right? So this is very different. And the one which you didn't know is half hitch. Half hitch looks something like this. I have no further explanation on how to make these knots. I can't make one normal granny knot also for the best of my life. So I can't explain how to draw this. Please ask a surgeon on how to make half hitch. Okay. So this is reef knot. Retroperitoneal hematoma, yes. Management will be surgery only. Mainstay will be this. Please ask a surgeon explanation on, and do, right? So this is very different. And the one which you didn't know is square knot is also known as a reef knot. Surgeon's knot is char and do, right? So this is very different. And the one which you didn't know is half hitch. Half hitch looks something like this. I have no further explanation on how to make these knots. I can't make one normal granny knot also for the best of my life. So I can't explain how to draw this. Please ask a surgeon on how to make half hitch. Okay. So this is reef knot. Retroperitoneal hematoma, yes. Management will be surgery only. Mainstay will be surgery, but first I gotta confirm. I gotta confirm that it's there by CT. Okay, so this is what it is. All right, so I think you guys got this. ये तो suture वाला सही हो गया. ये तो direct repeat है यार. Come on. What is this? Is it patella fracture? Is it bipartite patella? Bipartite patella, right? When you see this well corticated, not a see the sharp fracture line, very well corticated, sclerotic things. So this is bipartite. X-ray the other knee. Nothing needs to be done. Conservative management. Bipartite is just a fusion anomaly where it's a congenital anomaly. The patella formed. There's two pieces. उसको एक bone नहीं, दो bone बनना. There's two bone. Nothing needs to be done. The only thing is it's not a fracture. Okay. Next, well corticated का meaning है कि देखो यहाँ पे ऐसे cortex white लग रहा है. It is very well sclerosed, white, है ना? Very smooth margin. ये नहीं होगा. Okay. Right. Group link. Yes, sure. While performing emergency laparotomy for an unstable RTA case with blunt abdominal trauma, the surgeon notices a hematoma around the left kidney. What will be the next step? So this is something which I don't know if I've explained to you or not. So if you have an unstable patient who's already in the OT, that is the only indication of a single shot IVP. So this is a single shot. So if you got this correct, that's a happy face from my end. Okay. So CCT is something that you do in a stable patient. This person who's already in the OT, how will you take him for CCT? EFAST is not something that's going to show. CCT is something that you do in a stable patient. This person who's already in the OT, how will you take him for CCT? EFAST is not something that's going to show me anything about the collecting duct injury. What I am doing, what is my purpose now? Surgeon can already see if by renal injury hai. What is the main anything about the collecting duct injury? What person who's already in the OT, how will you take him for CCT? EFAST is not something that's going to show me anything about the collecting duct injury. What I am doing, what is my purpose now? Surgeon can already see if by renal injury hai. What is the main aim now? Main aim is to see is there any injury to the collecting system, to the excreting system? Because if it is there, then he would have to operate, right? So what he wants to see is कि उसको देखना है कि leak हो रहा है. So what they will do is they will just inject a dye. Intraoperatively, we have to operate. What is the anything about the collecting duct? So C is indication of a single shot IVP. So this is a single shot. So if you got this correct, that's a happy face from my end. Okay. So CCT is something that you do in a stable patient. This person was already in the OT. How will you take him for CCT? EFAST is not something that's going to show me anything about the collecting duct injury. What I am doing, what is my purpose now? Surgeon can already see if I renal injury hai. What is the main aim now? Main aim is to see is there any injury to the collecting system, to the excreting system? Because if it is there, then you would have to operate, right? So what he wants to see is कि उसको देखना है कि leak हो रहा है या नहीं. So what they will do is they will just inject a dye. Intraoperatively, we have X-ray available. So what we do is you inject the IV contrast, and after 10 to 15 minutes, I just take an X-ray. Every OT nowadays has an X-ray, right? So we will just take an X-ray. If I see, okay, this is the X-ray. If I see that from the collecting system, if this is the collecting system, is it normally draining or is there dehshat like this? All right, is there? Soon to know, I'll tell you why not be. Then you will ask me repeat. Abhi why not be, then you will be repeat. So this is where you will have excretion of the contrast. Okay, so this is what the surgeon wants to see. So before exploring, before opening kidney, he can't just open and see the entire ureter. How will he explore the entire collecting system of the kidney, whether leak is happening or not? So non-invasively, this is what is going to tell us. So if there is no collecting system injury, it is conservative management. Why would the surgeon explore the kidney? How would the surgeon explore the kidney for these leaks when he can get this information non-invasively? And otherwise, he wouldn't even have to operate. If there is no collecting system injury, he doesn't have to operate. Okay, so that is why the answer is single shot IVP. So what you will remember now as a concept, guys, if you didn't know it, renal do you know that there are various grades to any injury? One grade is just a perirenal hematoma. That is what the surgeon is doing. Conservative management. Second grade could be where you have a renal laceration. Again, nothing needs to be done. Conservative management. If you have a collecting system injury or you have complete non-enhancement, complete devascularization of the kidney, then the surgeon has to operate. So that's why we are doing a single shot IVP to just see whether there is any ureteric injury or not, okay, whether there is a urinoma formation or not. So what you will have to remember for renal trauma in stable patients, investigation of choice is CCT. CCT will tell you everything here, okay? But if it's an unstable patient who is directly in an OT, what you have to do is a single shot IVP. Just remember the name of this investigation. This is the only indication of doing a single shot IVP. All Unstable trick injury or non-enhancement vitamin. Otherwise, every OT nowadays. What is there any about the collect? So C, indication of a C. Okay, right. Nuclear, yes, sure. While performing emergency laparotomy for an unstable RDA case with blunt abdominal trauma, the surgeon notices a hematoma around the left kidney. What will be the next step? So this is something which I don't know if I've explained to you or not. So if you have an unstable patient who's already in the OT, that is the only indication of a single shot IVP. So this is a single shot. So if you got this correct, that's a happy face from my end. Okay. So CCT is something that you do in a stable patient. This person who's already in the OT, how will you take him for CCT? EFAST is not something that's going to show me anything about the collecting duct injury. What I am doing, what is my purpose now? Surgeon can already see if by renal injury hai. What is the main aim now? Main aim is to see is there any injury to the collecting system, to the excreting system? Because if it is there, then you would have to operate, right? So what he wants to see is कि usko dekhna hai ki leak ho raha hai या नहीं. So what they will do is they will just inject a dye. Intraoperatively, we have X-ray available. So what we do is you inject the IV contrast, and after 10 to 15 minutes, I just take an X-ray. Every OT nowadays has an X-ray, right? So we will just take an X-ray. If I see, okay, this is the X-ray. If I see that from the collecting system, if this is the collecting system, is it normally draining or is there dehshat like this? All right, is there? Sun to lo, I'll tell you why not D. Then you will ask me repeat. Abhi why not D? Why not D? Then you will be repeat. So this is where you will have excretion of the contrast. Okay, so this is what the surgeon wants to see. So before exploring, before opening kidney, he can't just open and see the entire urethra. How will he explore the entire collecting system of the kidney, whether leak is happening or not? So non-invasively, this is what is going to tell us. So if there is no collecting system injury, it is conservative management. Why would the surgeon explore the kidney? How would the surgeon explore the kidney for these leaks when he can get this information non-invasively? And otherwise, he wouldn't even have to operate. If there is no collecting system injury, he doesn't have to operate. Okay, so that is why the answer is single shot IVP. So what you will remember now as a concept, guys, if you didn't know it, renal do you know that there are various grades to any injury? One grade is just a perirenal hematoma. That is what the surgeon is doing. Conservative management. Second grade could be where you have a renal laceration. Again, nothing needs to be done. Conservative management. If you have a collecting system injury or you have complete non-enhancement, complete devascularization of the kidney, then the surgeon has to operate. So that's why we are doing a single shot IVP to just see whether there is any ureteric injury or not. Okay, whether there is a urinoma formation or not. So what you will have to remember for renal trauma in stable patients, investigation of choice is CCT. CCT will tell you everything here. Okay, but if it's an unstable patient who is directly in an OT, what you have to do is a single shot IVP. Just remember the name of this investigation. This is the only indication of doing a single shot IVP. All right, going ahead next. I already explained why not directly operate, okay? That is what I was explaining half an hour. 64-year-old man with history of coronary artery disease and peripheral vascular disease. Everybody is undergoing coronary artery bypass. His post-op is complicated by hypertension. We gave IV fluids, but now he's having abdominal pain followed by bloody diarrhea. Abdominal examination shows normal bowel sounds with no significant gouting or over-tenderness. So lactate is elevated. So what is the diagnosis? Ischemia happens. So what will be the area which gets affected? In short, asking the watershed area kya hai? Watershed area is splenic flexure. So either the rectosigmoid junction or the splenic flexure. Griffith point or Sudex point. Splenic flexure is Griffith or Sudex. SS don't go together here, right? So this is the Griffith point and that rectosigmoid point is the Sudex point. So this is the watershed area. What is Griffith or Sudex? SS don't go together here, right? So this is the Griffith point and that rectosigmoid point is the Sudex point. So this is the watershed area. Watershed area ka meaning nahi pata? Okay. So watershed area is where two arterial territories will stop. Okay, so what we have is watershed common. This is something which you should have known as a concept from like first year or from anatomy, but never mind, I will tell you. So यहाँ तक हमारी middle colic artery supply करता है. यहाँ पे you will have the left colic artery which supplies. Below it here you will have the iliac artery की branch superior. Have the iliac artery ki branch, superior rectal artery supply. So all of these are the watershed zones. So wherever there is drop in BP, it is this area where you have no vascular anastomosis which get affected. Okay, so this is what is the splenic flexure. MCM, sorry, I wrote MCM, SMA. Okay, SMA. Middle colic, I meant middle colic artery. So this is middle colic artery, this is left colic artery, which is a branch of IMA. Okay, so this is the point between SMA and IMA. All right. Lactic acidosis hoga na because ischemia ensued, right? So ischemia will lead to lactic acidosis. It can have bloody diarrhea. Mesenteric ischemia can have bloody diarrhea. Yeah. Yes. All right. Next, why would jejunum be affected? Small bowel, hepatic flexure, ascending colon. So this is just simple. इसमें कुछ why not this? It's the fifth point. If this is watershed areas will be affected. Okay. Others are not watershed. They have a lot of anastomosis within the vascular supply. Okay. Next. 35-year-old have ischemia because see बेचारे को hypotension हो गया, bypass surgery हुआ. That's why no ischemia. See, guys, little bit of clinical application we all have to learn. Okay, you won't be given a 200 question direct one liner paper that you will just answer. We have to do this analytical skill. We have to learn this. Okay, so just I know right now you are very fresh from the test, so you won't keep a मैंने जो mark किया वो क्यों नहीं mark? You just tell me that I mark this. Why is it not the answer? So this is what now, right now, when you've come to the discussion, all of you collectively have to be open-minded that okay, let's just see why this is the answer. You just can't be that मैंने वो बारा वो क्यों नहीं why not that? Okay, so you have to understand all of these questions. Understand from my perspective that I am trying to tell you the concept of every question or why that is the answer. Okay, so thoda we all have to cooperate and understand and be kind to one another. Okay, next 35-year-old female, known case of depression, presents to you with colicky pain, abdomen. Lab evaluation reveals raised PTH, high calcium, low phosphate. I could have easily tracked. With this. I could have easily made this raised PTH, low calcium, and high phosphate, and given one option as ultrasound abdomen. And I know for a fact that every one of you would have marked sesame B spect or technetium sesame B because it's a PYQ. But I didn't do this. Why? Because I was kind. I wanted you to have the confidence. कि मैम ये तो हमें आता ही था. All right. So first of all, what is the case here? This is primary PTH. This is primary hyperparathyroidism. Primary hyperparathyroidism in the most common cause is parathyroid adenoma, PTH adenoma, investigation of choice, sesame B spect. If you still don't why not technetium sesame B? Where were you so far? ये तो अभी I9 में हो चुका ना ये mistake. Can't do this mistake again. So technetium sesame B spect. Both are scans that I can use. Remember, everywhere spect is a 3D investigation. The name has CT. That will be better than technetium 99. All right. So if spect is in the option with sesame B, mark that. If this is not in the option, then we go for sesame B. All right. So spect is a 3D investigation. Technetium is like an X-ray, 2D. So this is something which is going to be better. All right. This is that will be better than technetium 99. All right. So if SPECT is in the option with sestamib, mark that. If this is not in the option, then we go for sestamib. All right. So SPECT is a 3D investigation. Technetium is like an X-ray, 2D. So this is something which is going to be better. All right. This is what you have to understand. Next, 40-year-old female. This is again something which I have explained so many times. 40-year-old female presents with jaundice and phenochromon. LFT reveals bilirubin and GGT. Ultrasound reveals scleroatrophic gallbladder with impacted calculine gallbladder and dilated CBD. So do I know what is going on in the distal CBD? I don't. Impacted cal calculine gallbladder and dilated CBD. So do I know what is going on in the distal CBD? I don't. So what do you do next? I do an MRCP. I diagnose the CBD stones. Only then can I go for ERCP, which is an invasive investigation. To do next, all LFT reveals bilirubin and GGT. Ultrasound reveals scleroatrophic gallbladder with impacted calculine gallbladder and dilated CBD. So do I know what is going on in the distal CBD? I don't. So what do you do next? I do an MRCP. I diagnose the CBD stones. Only then can I go for ERCP, which is an invasive investigation, which uses contrast, diagnosed CBD. So do I know what is going on in the distal CBD? I don't. So what do you do next? I do an MRCP. I diagnose the CBD stones. Only then can I go for ERCP, which is an invasive investigation, which uses contrast, which has radiation, and that is why not ERCP next. Okay, so that is why the next step is always investigation of choices MRCP. All right, that is what you have to remember. Okay, guys, you can't get this wrong. You can't still get this wrong. This I have explained so many times. Okay, so this is something that you have to know. When they tell you, if I tell you ultrasound showing me distal CBD stone, only then I will go for ERCP. Only then I will go for it. No. When they tell you, if I tell you ultrasound showing me distal CBD stone, only then I will go for ERCP. Then I will go for ERCP. If distal CBD is dilated, first we need to know the cause and then MRCP. Okay. You can't go for cholecystectomy without knowing what this is. So how can you go for a surgery knowing कि उसको CBD stone है? Can't do that. ना कि पहले ये निकालो, बाद में ये देखेंगे. It's a combined disease. No, the surgeon will have to remove the stones also if they are undergoing cholecystectomy. Okay, so this is why PET का कोई role नहीं है. Next, this is knowing what it be. If no, that is what I in Go 40-year-old 2D. So this is something which is going to be better. All right. This is what you have to understand. Next, 40-year-old female. This is again something which I have explained so many times. 40-year-old female presents with jaundice and pain abdomen. LFT reveals bilirubin and GGT. Ultrasound reveals scleroatrophic gallbladder with impacted calculine gallbladder and dilated CBD. So do I know what is going on in the distal CBD? I don't. So what do you do next? I do.
Next presentation and asked quite frequently in the last 5 years is choledocholithiasis. So choledocholithiasis is basically stones in CBD. Now stones in CBD, 90% stones are secondary to GB stones, secondary to gallbladder stones, means from the gallbladder they come down. But you also need to know that 10% of these stones are primary CBD stones, which are formed in the CBD, and they are usually brown pigment stones. They are brown pigment stones, and we discussed that brown pigment stones will occur due to infection. So cholangitis infection, Clonorchis, Ascariasis can predispose to stones within the CBD itself. Now, the clinical features, if you have a stone in the CBD, right? So if there is a stone in the CBD which was here and now the stone has come here, this patient can either be asymptomatic, we get a lot of such patients, or there can be obstructive jaundice because it can block the CBD. But the two presentations which I really want you to know, and these two were hot topics around 6.
When MRCP, I diagnose the CBD.
Then there was a gap of 3 or 4 years when they were not asked at all. But in the last 2 years, INS CT has again become very fond of them, and it is asking questions from Charcot's triad and Raynaud's pentad repeatedly. So Charcot's triad is seen in cholangitis. Because of this stone, cholangitis means inflammation of the biliary tree. That is cholangitis. And the patient is going to come with intermittent pain, intermittent fever, intermittent jaundice.
right? Why intermittent? Because this stone will block, then it will move in position, then again block, then move in position. So there is intermittent pain, intermittent fever, and intermittent jaundice. That is Charcot's triad. You should be crystal clear about this. Reynolds pentad is Charcot's triad. So you will have Charcot's triad plus shock or hypotension, and you have altered mental status plus altered mental status. That is Reynolds pentad. That is Reynolds pentad. Now, again, a very, very important thing, investigation of choice. So to diagnose CBD stones, the investigation of choice is MRCP. Again, it is a diagnostic modality, magnetic resonance cholangiopancreatography. That is the investigation of choice to diagnose CBD stones. You can see here, this is the CBD, this is the CBD, this is the duodenum. And in this CBD, can you see these two blackish rounded things? These are the stones. These are the CBD stones, which we can see on MRCP. MRCP is an MRI, I've told you. Also, Bailey says that the investigation of choice for CBD microliths, very small CBD stones. So investigation of choice for CBD microliths is EUS, endoscopic ultrasound. But most of the questions have been asked regarding CBD stones. It is MRCP, not ERCP. Please mind you, not ERCP. I will tell you what ERCP is in some time. Now, in the latest Bailey, they've added a new table where they've highlighted the risk factors for CBD stones. And this is very important because I want to tell you that when we were residents, as a first year resident, the first 6 months, your role is to work up patients, to prepare patients which can then be operated. And lab poly was a frequent surgery on the list. So as a first year resident, it was my duty to take the history of the patient, to find out whether there's any history of jaundice or the patient has any jaundice at present, to see the liver function test if they're normal or deranged, and to see what is the diameter of the CBD. So these three things were prominently written on the front of the patient file, because when the surgeon was operating, he used to see these three things and then plan they're normal or deranged, and to see what is the diameter of the CBD. Take the history of the patient. 6 months. Your role is to work up patients, to prepare patients which can then be operated. And lab poly was a frequent surgery on the list. So as a first year resident, it was my duty to take the history of the patient, to find out whether there's any history of jaundice or the patient has any jaundice at present, to see the liver function test if they're normal or deranged, and to see what is the diameter of the CBD. So these three things were prominently written on the front of the patient file, because when the surgeon was operating, he used to see these three things and then plan his surgery. Now, based on these three things, we can assess the risk of CBD stones. So if there is no history of cholangitis or pancreatitis, if the liver function tests are normal and the CBD diameter is less than 6 millimeters, then there is low risk of stones, just 2 to 3%. So this patient straight away goes for a lab poly, right? Surgeon would do a lab poly, no further investigation required. But if there is history of cholangitis or pancreatitis or jaundice, liver function tests are 2 times deranged, or 8 to 10 millimeters is the CBD diameter, then in these patients, we do an MRCP before surgery. Right, so you will do an MRCP to diagnose the stones, and then if there are no stones, you do surgery. If there are stones, we will discuss how to treat them in 2 minutes. High risk of stones when the patient has jaundice. Okay? When actively jaundice, not a history of jaundice, has jaundice at that time. The liver function tests are 2 times deranged, and the CBD diameter is more than 10 millimeters. CBD diameter more than 10 millimeters also is a high risk indicator for CBD stones. Again, in these patients, we will do MRCP before surgery. First, do an MRCP to confirm the diagnosis of CBD stones. So I've shown you what CBD stones look like on MRCP. Let's now talk about the management of CBD stones. And I always like to divide them into 3 situations, because questions in your exams will also come this way only. So first situation is if CBD stones are detected, before lab poly. Okay, so that means our resident was working properly. He did a proper workup and he was able to diagnose that there are CBD stones on MRCP. He sent the patient for MRCP and CBD stones were diagnosed. Now, how do we manage this patient? So this patient is managed by ERCP followed by lab poly. We don't do lab poly first, we do an ERCP first. Now, what is ERCP? ERCP stands for endoscopic retrograde cholangiopancreatography. A long name, what does it mean? Let's understand. So here we use a scope, right? We use a scope, an upper GI endoscope. So this is an endoscope with a side viewing camera. So I'm going to get it inside the duodenum, and then I'm going to enter into the ampulla of water, right? The ampullary opening where the CBD and the pancreatic duct is opening. I'm going to enter here. And when I'm entering here, I'm going to make a cut. Where is the cut going to be made? Cut at 11 o'clock. So we make the cut at 11 o'clock to cut the ampullary opening so that we can enter there. And then we can inject a dye. So whenever you see an ERCP image, you will always see an endoscope. Whereas MRCP, you did not see an endoscope. You cannot see an endoscope. ERCP, you will always see an endoscope. So that is one point of difference. Now in ERCP, then we can inject dye and that will delineate the biliary tree tube. So ERCP also can be diagnostic, but an additional advantage of ERCP is that it can be diagnostic plus therapeutic. Means I can cut that ampullary opening and I can retrieve the stones, right? I can retrieve the stones. So it is both diagnostic and therapeutic, but it has certain risks as well. So what are the risks or complications of ERCP? The most common complication is pancreatitis. Because when you're entering into the ampullary opening, there can be back pressure changes which can give rise to pancreatitis. And other is duodenal perforation can be there. There can be duodenal perforation in these patients as well. So because there are complications, would you like to use ERCP for diagnosis or MRCP for diagnosis? Obviously MRCP, it is non-invasive. So to diagnose CBD stones, mind you, I will do an MRCP. Once I have diagnosed CBD stones, then I will do an ERCP to remove them. Not ERCP first. Please remember that. That has been asked in multiple exams. So that is what we do. We do an ERCP followed by... So because there are complications, would you like to use ERCP for diagnosis or MRCP for diagnosis? Obviously MRCP, it is non-invasive. So to diagnose CBD stones, Mind you, I will do an MRCP. Once I've diagnosed CBD stones, then I will do an ERCP to remove them. Not ERCP first. Please remember that. That has been asked in multiple exams. So that is what we do. We do an ERCP followed by lab chole if you detected CBD stones prior to surgery. Second situation is that CBD stones detected during the lab chole. Detected during lab chole. Okay. So this used to happen sometimes. Even if the resident used to do a good workup, sometimes the surgeon is operating and he feels that there are stones in the CBD. So firstly, what the senior used to do was call the resident and give him a nice dose. But now what do we do? How do we manage this patient? So the management of this patient is going to be lab chole plus lab exploration of CBD. Plus lab exploration of CBD. Right? So we are going to explore the CBD and remove the stones. So once we remove the stones from the CBD, this is my CBD, I've done a cholecystectomy, I've removed the stones. Then what do? We insert a T tube. Then we are going to insert a T tube, right? So we are going to insert a tube which is in the shape of a T. We insert a T tube and we get it out of the skin. This is what a T tube looks like. It's been asked in the exam. It looks like a T. You can explore the CBD and remove the stones. So once we remove the stones from the CBD, this is my CBD, I've done a cholecystectomy, I've removed the stones. Then what do? We insert a T tube. Then we are going to insert a T tube, right? So we are going to insert a tube which is in the shape of a T. We insert a T tube and we get it out of the skin. This is what a T tube looks like. It's been asked in the exam. It looks like a T. You can see the T tube here. The T tube has been inserted here. This is the T tube and we get the T tube out. Right, so we insert a T tube here and we close the CBD over the T tube. Now, this T tube I've inserted because 7 to 10 days later, I will do a T tube cholangiogram. I will do a T tube cholangiogram. Means I'm going to inject the dye through T tube. So when I do a T tube cholangiogram, you can see here that this is going to delineate the biliary tree, and eventually the dye is going to come into the bowel as well. And if there are any residual stones, those stones will show up as well. So when you inject the dye, you will see any residual stones present as well. 10 days later, I will do a T tube cholangiogram. I will do a T tube cholangiogram. Means I'm going to inject the dye through T tube. So when I do a T tube cholangiogram, you can see here that this is going to delineate the biliary tree, and eventually the dye is going to come into the bowel as well. And if there are any residual stones, those stones will show up as well. So when you inject the dye, you will see any residual stones present as well. So this T tube cholangiogram, if residual stones are present, if residual stones can be present or they can be not present. If they are not present, very good, remove the T tube. We remove the T tube. Okay. But if residual stones are present, we retain tube for 2 to 3 weeks. So we retain the tube for 2 to 3 weeks, and in 2 to 3 weeks, a channel will form, a passage will form, a track will form, and then we will introduce a colidocoscope. We introduce a scope to remove stones, to remove the stones. So this method of using a T tube during surgery is called the Burheen technique. This is the Burheen technique of managing CBD stones in case you encounter them during surgery. Okay? Now the final situation is that CBD stones are detected after surgery. CBD stones after lap chole. That is the final situation. Okay. So after lap chole, CBD stones, how will the patient manifest? The patient is going to come with pain, patient can come with fever, patient can come with jaundice. And we discussed multiple times what is the investigation of choice? Is it MRCP or ERCP? To diagnose, it is MRCP. I told you, MRCP is the investigation of choice. Now, if the stones are detected within 2 years of lap chole, then we call them residual CBD. Manifest. The patient is going to come with pain, patient can come with fever, patient can come with jaundice. Stones after lap chole. That is the final situation. Okay. So after lap chole, CBD stones, how will the patient manifest? The patient is going to come with pain, patient can come with fever, patient can come with jaundice. And we discussed multiple times what is the investigation of choice? Is it MRCP or ERCP? To diagnose, it is MRCP. I told you, MRCP is the investigation of choice. Now, if the stones are detected within 2 self-limiting, but if there is a hilum, and these if the stones are detected within 2 years of lab only, then we call them residual CBD stones. Then we call them residual CBD stones. Some people like to call them retained CBD stones as well. Means they were stones which are left behind from the gallbladder, right? From the gallbladder only. But if these stones are seen after 2 years in the CBD, then they are called recurrent CBD stones. Then they are called recurrent CBD stones or primary CBD stones. Because if they are detected after 2 years, then these stones are more likely to have been formed inside the CBD. And I told you 10% stones can form inside the CBD. So these would be primary CBD stones if they are seen after 2 years. Now, once you diagnose the stones, how do we manage them? We manage them using ERCP followed by plus sphincterotomy, and we remove the stones. So we cut the sphincter, we enter the ampulla, and we remove the stones. ERCP plus sphincterotomy is what we will do to remove these stones. So these are the three scenarios which you need to know regarding how to manage CBD stones. Questions are also asked this way only. in the exam. Before I end this module, very important that you know about MRCP and ERCP. I've highlighted it adequately, and all these presentations are super important for the exam. So I would like to end by showing this picture of a Leothrix. This is a beautiful bird, a very colorful bird, which I clicked at Saptal. And I also want to discuss this graph with you. So there is a very nice book which I read a year back called Tiny Habits. Now, Tiny Habits is a book which tells you that the most common reason why New Year resolutions fail, or why you are only able to study for a few days and then the momentum fizzles down, is because you're making unreasonable targets. Right? So if you first January we all make a target that I'm going to do 100 push-ups every day, or I'm going to go
तो दिस पहले हमेशा एमआरसीपी करो, एमआरसीपी करके आप लोग स्टोन को निकाल दो वहीं से, लेकिन लोग तो
these stones, only then can I go for ERCP, which is an invasive investigation, which uses contrast, which has radiation, and that is why not ERCP next. Okay, so that is why the next step is always investigation of choices MRCP. All right, that is what you have to remember. Okay, guys, you can't get this wrong. You can't still get this wrong. This I have explained so many times. Okay, so this is something that you have to know. When they tell you, if I tell you ultrasound showing me distal CBD stone, only then I will go for ERCP. Only then I will go for ERCP. If distal CBD is dilated, first we need to know the purpose and then MRCP. Okay, you can't go for cholecystectomy without knowing what this is. No, how can you go for a surgery with knowing कि उसको CBD stone है? Can't do that. ना कि पहले ये निकाल लो, बाद में ये देखेंगे. It's a combined disease. No, the surgeon will have to remove the stones also if they are undergoing cholecystectomy. Okay, so this is why PET का कोई role नहीं है. Next. 10-year-old child presents to the emergency, sudden onset by temporal. Yeah, I hope it Was clear? ये किसी ने गलत नहीं करा है. So it's a child, but it is MRI. So you will not mark craniopharyngioma if MRI is done in a child. Yes, CT will show you calcification. Yeah, CT will show you calcification. CT will show you cystic changes. But can't MRI be done in a craniopharyngioma? So here what you are seeing is a suprasellar mass. Can you see the pituitary is completely normal? This is pituitary, this is stalk, and then I see a lesion. This is craniopharyngioma. Bitemporal hemianopia. All right, so sudden onset to ho hi sakta hai na. Any day when it happens first, it will be sudden only. Why not? Pituitary adenoma would involve the pituitary. Dark cleft cyst is something which will not enhance white. Apoplexy will be something again within the pituitary. It will not be above the pituitary. Apoplexy will happen within a pituitary adenoma. Yes, it will happen within a pituitary adenoma, and there should be a pituitary adenoma for that. This is suprasellar. Okay, guys. So what you have to remember is, please stick to basics. Don't jump to the answers. Okay. Pituitary apoplexy will be within pituitary. I can see a normal pituitary here. Okay. So how apoplexy will appear? You will see that pura yahan pe white hai, pura white like this. Okay. And this is the sella that I have drawn for you. So it will extend from the sella. Got it? Pituitary adenoma versus apoplexy. Adenoma is the tumor. Apoplexy is the bleeding, acute episode of bleeding within the tumor. Okay. That is what you want to remember. In previous question, ultrasound given is showing calculus where? Gallbladder. How do I know what is there in distal CBD? I don't. That's why we have to undergo MRCP. Okay, chalo. Next. 27-year-old primary gravida is found to have a thyroid nodule. Serum TSH is normal. Remember I told you thyroid nodule and next step will be thyroid function. Normal hai. What do we do next? Remember the flow chart of thyroid. This is ultrasound. So we did the ultrasound. Is it looking? Next step will be thyroid function. Normal hai. What do we do next? Remember the flow chart of thyroid. This is ultrasound. So we did the ultrasound. Is it looking good or bad? Irregular margins, microcalcifications, internal vascularity is not looking good for her. So I am suspecting a malignancy. We have to go for the next step, fine needle aspiration. This is not very correct. Fine needle aspiration cytology. FNSE is what we go for. Okay. MRI of the neck, radionucleotide, no point. MRI has no point in thyroid. Radionuclide scan is no point. I can't even give her radiation. She's pregnant. Can't just reassure her. We have to rule out malignancy. Okay. So we have to rule out malignancy. So we do an FNSE. Okay. FNSE is not done. Who said? Who has said this to you that in thyroid we don't do FNSE? What do we do then? We only do FNSE. We don't do biopsy. Okay, so biopsy is not done. So I agree that this should have been cytology, but the fact that they've written fine needle aspiration, it means that we're using a small needle. So fine needle aspiration, cytology should have been the best answer. But again, nothing else matches here. Okay, so vascularity से क्या हुआ? All malignancies are vascularity only. Yeah, internal vascularity से bleed होगा. No, 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 guys, इतना दिमाग मत लगाओ. So every malignant, do you know something called TIRAD score? In that we see Doppler, right? So this is just basically every malignant nodule will have internal vascularity. So this is where you have. This is where you have to suspect that it is a malignant nodule. I have to confirm what it is and then plan further management. Okay. What were you thinking? कि thyroid के अंदर aneurysm बन गया है? It's microcalcification. No, 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 please. Nothing else. Could be random. So this is FNSU. All right, please. Moving on. 35-year-old trumpet blower presents with her next swelling. All right. That's follicular adenoma versus carcinoma. FNSE can't tell us. So that's why when I get that FNSE is telling me after I do FNSE that there are follicular cells, that that we will go for hemithyroidectomy. Na? तो अभी तो वो सवाल आया नहीं. उसके लिए we have to do FNA first. Then I get follicular cells. Then I reach there. Okay. Biopsy is not done because thyroid is a very vascular organ. That's why we never do a biopsy in thyroid. Okay. Right. Next. Yes, TIRADS includes Doppler. I hope here everybody has no doubt. Trumpet player, neck swelling, air filled, X-ray है, air है, ठीक है, तो laryngocele. Can I move on, guys? Hopefully no problem. This is not liar sign. This is not liar sign. Liar sign is where at the bifurcation of can I move on? There's no doubt. Trumpet player, neck swelling, air filled, X-ray है, air है, ठीक है, तो laryngocele. Can I move on, guys? Hopefully no problem. This is not liar sign. This is not liar sign. Liar sign is where at the bifurcation of the carotid, ICA and ECA, I have a tumor. I have a carotid body tumor. Okay. In the question, trumpet blower was mentioned. Okay. You forgot to see it. So, agar nahi bhi mention kara, nothing else has an air here. Hydroglossal cyst doesn't have air. Brachial cleft cyst doesn't have air. Carotid body tumor doesn't have air. So, this is kala kala air. So, laryngocele. 22-year-old woman comes to the OPD for foot pain. This I discussed in buzzword class, isn't it? Pain is located at the heel.
The name comes to OPD with the condition movements of footprints.
The moment she gets up, remember the first step will be pain. Patient is a soccer player, she enjoys running, high heartbeat hai, direct pressure elicits sharp pain, but squeezing test is negative. So this is how I ruled out Mulder sign for Morton's neuroma. Squeeze test. Mulder sign for Morton neuroma will have this test positive here. So this is simple plantar fasciitis, where you have pain on the first step, usually associated with people who have a high plantar arch. Okay. Here you said Doppler is not component of what? Of TIRADS. So look, let's in the end just remind me. I will show you TIRADS. All right, I will show you the TIRADS staging where we do mention about the vascular. All right. So even if we don't include it in TIRADS score, guys, but when they give you the finding, you can still take it as malignancy. Yeah. I'm not asking you to give the TIRADS score. What I'm asking you is this benign or malignant? There are malignant signs, right? So that's why the next step in a thyroid nodule has to be FMC. All right. That's what I'm saying. Okay. All right. TIRADS has nothing to do with this question right now. All I'm telling you is nodule hai, ultrasound kiya, ultrasound showing or malignant findings, right? Next. 22-year-old soccer player comes to the ED for evaluation of a knee injury. Other players on the field, right? Next. Thing to do, right? So that's why the fine that's the Doppler is right. When she gets up, remember the first step will be pain. Patient is a soccer player, she enjoys running, high heartbeat hai, direct pressure elicits sharp pain, but squeezing test is negative. So this is how I rule out Mulder sign for Morton's neuroma. Squeeze test. Mulder sign for Morton neuroma will have this test positive here. So this is simple plantar fasciitis. So this is how I ruled out Mulder sign for Morton's neuroma. Squeeze test. Mulder sign for Morton neuroma. We'll have this test positive here. So this is simple plantar fasciitis, where you have pain on the first step, usually associated with people who
हेलो।
हेलो,
हाँ,
क्या कह रहा सर?
चाय बना लो बस।
कौन बनाऊं क्या?
बना लो तो बना लो।
People who have a high plantar arch. Okay. DTR, you said Doppler is not a component of what? Of TIRADS. So look, let's in the end just remind me. I will show you TIRADS. All right, I will show you the TIRADS staging where we do mention about the vascular. All right. So even if we don't include it in TIRADS score, guys, but when they give you the finding, you can still take it as malignancy. Yeah. Look, I'm not asking you to give the TIRADS score. What I'm asking you is this benign or malignant? There are malignant signs, right? So that's why the next step in a thyroid nodule has to be FMC. All right. That's what I'm saying. Okay. All right. TIRADS has nothing to do with this question right now. All I'm telling you is nodule hai, ultrasound kiya, ultrasound ke बाद malignant findings, right? Next. 22-year-old soccer player comes to the ED for evaluation of a knee injury. Other players on the field recoiled hearing an audible pop. Right knee is grossly swollen. So when you have this image,
Twenty-two years soccer player comes to the emergency department of injury. Active earlier time valid data the patient felt a knee buckle while planting her right foot to kick the knee buckle while planting her right foot to kick the ball. Other player on the field recalled hearing an audible poke as she falls into the down. On physical examination, the right knee closely swollen with a limited range of motion due to pain. She guarding examination and increased the anterior translation of the tibia and the femur. Total control at a site for the pain outcomes. Early
immediate hemarthrosis. Does it favor a cruciate ligament injury or does it favor a meniscally swollen? So when you have this immediate hemarthrosis, does it favor a cruciate ligament injury or does it favor a meniscal injury? It favors a cruciate ligament injury, all right? And you also have been given increased translation of the tibia. So this is anterior cruciate ligament injury. So it favors cruciate, ACL is more commonly injured. Menisci will usually have a late gradual hemarthrosis. Okay, this is what you need to remember. I hope this is fine. See,
लंगर चलता था 207 लंगर चलता था 207 लंगर
6-year-old boy, menisci will usually have a late gradual Keymark process. Okay, so this is what you need to remember. I hope this is fine. 6-year-old boy brought to the OPD for evaluation of back pain. 29. What about 29? 29 is a bit, sure. So what we have here is the pain at the first step associated with high arch. Please see the buzzword class last slide. I've given an entire table that is suggestive of plantar fasciitis. A stress fracture will have pain throughout. It's a pain, right? It's a fracture, right? It will not have pain on the first step only, all right? That's why. So this is something which is a buzzword where she is getting pain when she is getting up from sitting, all right? That is what you need to remember. Next question. 6-year-old boy is brought to the OPD for evaluation of back pain. One thing that has been given to you is incontinence, which can again lead me to thinking that okay, probably LCH. So this is something where pituitary, posterior pituitary tends to be involved in LCH, right? Hand shoulder Christian triad, and the X-ray is very typical where you have a vertebra plana, right? So this is plantar hand cell histiocytosis. This flattening of the vertebra is again something that you can see in Ewing sarcoma also rarely because it's a destructive tumor, but this posterior pituitary polyuria, polydipsia, incontinence of diabetes insipidus is not something that I will expect in Ewing's sarcoma. Okay, so we have hand, shoulder, Christian triad. Okay, in LCH, hand, shoulder, Christian triad. Can somebody tell me what is there in the triad? One is diabetes insipidus, as I said. What else? What else will you see here? You will see these calvarial lesions, calvarial lytic lesions, skull में lytic lesions मिलेंगे, and you will see exophthalmos. There will be protrusion of the orbit if it extends, or vital LCH will also be there. Okay, so this is the typical triad. So triad is not fulfilled here, but diabetes insipidus takes you towards this. What is Mazur-Brown syndrome? Anybody can tell? What is Mazur-Brown? Fibrous dysplasia plus myxomas, right? Fibrous dysplasia plus myxoma is Mazur-Brown. Fibrous dysplasia plus precocious puberty is McHugh-Albright. Okay, next. So here, again, a lot of you probably got this wrong. What is this? Right air under the diaphragm, perforation. Pneumoperitoneum. Can it be seen in duodenal perforation? Most definitely. Can it be seen post laparoscopy? Yes, laparoscopy. I am putting air. I'm putting CO2, so I can definitely see air. Iatrogenic cause of pneumoperitoneum. Can intestinal obstruction perforate? Definitely, it can perforate. Chilaiditi syndrome. Chilaiditi syndrome is something where you have interposition of the colon. So this is where I will see a picture like this. There is air under the diaphragm. There is air under the diaphragm, but then you will see hostrations. You will see hostrations here. Are you seeing hostrations here? Seeing any hostrations here. So that is why the answer will be Chilaiditi syndrome. Okay, right? कहीं पे कुछ भी आंसर हो, अपने को सही आंसर ढूंढना है. I am telling you why it is Chilaiditi syndrome. Does that explanation give you logic? क्या उसमें logic लग रहा है? If yes, then you accept. Otherwise, Shraddha to hai hi apni apni Shraddha sabke paas. So you can use your Shraddha. So Chilaiditi syndrome is this can never be Chilaiditi syndrome. Can I tell this patient to ghar jao, you have Chilaiditi syndrome without seeing hostration? No, this is no. There are no hostration. The simple air fluid, right? The simple air under the diaphragm, right? So obstruction can perforate. No, acute intestinal obstruction can perforate, leading to air under the diaphragm. Yes. So I mean, it is a difficult question. You can think कि मैम obstruction बोला है ना, obstruction का perforation तो बोला नहीं है. So it may not be obstruction, but then my defense is that this can never be Chilaiditi syndrome because there I will see the hostration. Here hostations are not there. So theoretically obstruction can perforate. Yeah, patient तो बोलेगा नहीं perforation हुआ. Patient will say obstruction, but obstruction can have pneumoperitoneum. So my theory is just that my duty as a radiologist is to distinguish pneumoperitoneum versus pseudo-pneumoperitoneum. Isn't it? So that is what we have to do here. All right, next. 29-year-old woman comes to the ED with persistent vomiting and abdominal pain, crampy, diffuse, and getting worse. So 3 days पहले normal bowel movement, has no diarrhea, hyperactive bowel sounds. So all of these are findings of intestinal obstruction. I'm seeing multiple air fluid levels. I'm seeing multiple dilated bowel loops. So this is a small bowel obstruction. Yeah, central loops are dilated. So this is history of appendicectomy. Why? Because what is the most common cause of small bowel obstruction? Adhesions, right? So adhesions are going to form after small. bowel obstruction history, prior surgery is what is something that can lead to adhesion formation. ये gallstone करेगा, ये pancreatitis करेगा, इसका कुछ relevance नहीं है. All right, but why after 6 months? No reason. Any history could have been there. So 6 months नहीं है important, appendicectomy important. Okay. So next, 3-month-old baby presents to you with jaundice.
हेलो. हाँ.